Welcome. Thank you for coming to our Lucent Symposium. And I want to give you just a couple updates about the Lucent program. This is our building year, as you know. We are now identifying resident scholars for the coming year. We have a great group of resident applicants from medicine, peds, med peds, and family medicine. We have 3 applicants for the fellow slot. There'll be a full-time Lucent fellow in the coming year. And we also have faculty applicants to be part-time Lucent scholars from those different departments, as well as we're engaging with some community leaders who may want to participate as Lucent scholars. So we have an exciting year coming up. By this time next year, in fact, by fall, we expect to have our Lucent Symposia twice a month. And the fall series will be especially focused on building primary care leadership skills. And then as winter and spring progress, we will also engage some of the scholars in presenting their own practice innovation projects, and we'll learn from each other as we go through the year. And the sessions will continue to be open even if you are not a Lucent scholar. They will be open to students, residents, faculty, and community partners. So those are updates on our Lucent program. I'm happy to introduce today Molly Martin. Molly is a pediatrician who did some of her training. She was an RWJ scholar here and learned her health services research training skills. She started her work on the west side of Chicago during that period and has developed it further in the subsequent years. She's currently a faculty member at University of Illinois at Chicago, doing community engaged research and also practicing in an FQHC on the west side. And she's going to tell us more about her work, and especially her work on community health workers, which is a hot topic here at U of C and all over the place. So thank you for coming to join us.
Nope's off. Can you hear me okay? Yes. Okay. So thanks again for having me here. And just to build a little bit off what Deb said, I was a PEDS resident here from 1999 to 2002, and then I did the Robert Wood Johnson Clinical Scholars Program, which used to have a site here, because I wanted to do more than just clinical care. And I always knew that that's what I wanted to do, and RWJ gave me an avenue to do that. One of my mentors is here, David Meltzer, and I started the RWJ Clinical Scholars Program saying, I want to study community health workers. And they said, it's not going to work. You only have 2 years, and it's too messy, and all this CBPR stuff and all that. But I really wanted to. It was what I wanted to do, and I did conduct some programs, mainly on the south side in South Chicago, and I got some data moving, and I did a small study, and also looking at some stuff with asthma, some stuff with car seats, and it enabled me to get a faculty position then at Rush, and I was at Rush for almost 9 years then, where I did the majority of my research. And so a lot of what I've built in terms of my research career has been through Russia, and then I moved to UIC about 2 years ago. So I'm 75% research and I'm 25% clinical. I practice in the Mile Square Health System, so on Roosevelt and Wood. And I'm going to talk today not about my research per se, but just kind of giving an overview about community health workers. So there's going to be very little of my own stuff in here, except for my policy aspect, because I do a lot of policy work. So I'm going to try and talk about where community health workers have been, where we are right now in terms of implementation and policy and research, and then hopefully where we can go in the future. So just as a little outline, I'll talk briefly about community level health care in the United States, and then some community health worker basics, the evidence, policy and implementation, and some outstanding questions regarding community health workers. So let's start with just a couple of case studies to start thinking about why, as a clinician, this might matter to you. So say your patient is Betsy, a 45-year-old female who's been referred multiple times for a screening mammogram but's never gone. She always smiles, says, thank you, doctor, I'll go. She comes back, she never went, okay? What can you do? How about Anton, a 56-year-old male, type 2 diabetes. He's had frequent emergency room visits, hospitalizations for diabetes. He's been unable to be contacted via phone, and the hospital case manager has written him off. I can't do anymore. I don't know what else to do to contact this person. Or how about Gabriel, who's a 9-year-old with asthma. He's been hospitalized once this last year and in the emergency room 4 times. You've maxed him out on inhaled corticosteroids. He's on everything you got. And he still has symptoms, and you're frustrated now. You're in clinic. What can you do with him? So hopefully at the end we can talk about some options. So let's start with thinking briefly about community level healthcare. So you've probably seen figures like this in the past. It's not new for anyone. In the United States, we spend more on healthcare than anybody else, more per capita and also in terms of our GDP, and yet we have worse outcomes than everybody else. So something about our system is definitely not working correctly. And here's one way that Paul Farmer described it one time, and many of you have probably heard his name before, but he's one of the founders of Partners for Health and is at Harvard and does a lot of work around this. But a good healthcare system really has three arms. It has tertiary care, which is the hospital system. It has an outpatient clinical care, and then it has community level care. So here in the United States, we have great tertiary care, right? University of Chicago Hospital, excellent, right? If you're having a heart attack, bring me to the hospital. We'll save you. It's great. So we have fantastic tertiary care here in the United States. We have pretty decent outpatient clinical care too. There's some problems with it, but there's lots of clinical care options for the outpatient setting. But we really don't have a community level system for care, for services around health. This is the opposite of a lot of developing countries. So if you were to look at some of the countries in Africa, they might have a really robust community level system. And that's really usually driven by community health workers. So they have community health workers in villages all throughout the country, but there may be only 2 or 3 hospitals in the entire country, right? So a lot of developing countries are really struggling on maintaining their tertiary care and some of their outpatient clinical care, but have built quite a robust community level care. So different problems in different countries, but our problem is we don't have anything hardly in that community level care arm. So community health workers are something that has been growing in the United States in terms of popularity as a solution to that problem that we don't have access to health care in the community level. So the best definition that I've found and that I like to promote for community health workers is the one that's been authorized by the American Public Health Association Community Health Workers section. So community health workers are frontline public health workers who are trusted members of and/or have an unusually close understanding of the community served. Community health workers build individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities such as outreach, community education, informal counseling, social support, and advocacy. How do they work? Well, community health workers empower community members to identify their own needs and implement their own solutions. And this leads to improved community and personal self-efficacy. So nowhere in this definition or in this kind of how do they work do you see the words education, okay? They may be educators, they may serve that role, but it's really more about empowerment. It's really more about building self-sufficiency. And this is an interesting quote that sort of sums up a lot of what makes community health workers powerful. It may be the very fact that community health workers are not experts, that they most likely do not differ in terms of education, power, or social capital from their clients that makes them most effective. And so if you're thinking that this is what really makes community health workers effective, which is what a lot of us in the field believe very strongly, then we're going to run into some issues when we talk later about training and certification and what kind of educational levels and what kind of background and what kind of matching and different things like that do community health workers have to have. Oh goodness, if these are the criteria that are needed for them to be effective. So there are a lot of names for community health workers. And this is what will complicate your lit search endlessly, right? This is just a beginning of names. The way that the workforce is promoting that we discuss community health workers is that we use the term community health worker maybe in the same way as you would use the term physician, okay? It's a job classification. It's a workforce classification. So within physician, there are multiple kinds of physicians, right? Pediatricians, surgeons. You could subspecialize beyond that. You could be a cardiac surgeon. You could be a general pediatrician, you know, so there's all different levels. And so a patient navigator is a type of community health worker. And it's not wrong to call yourself a patient navigator if that's what you do. If you do patient navigation, that's what you're hired to do, and that's what your training is all around, that's fine. But for workforce classification issues, it should be remembered that this is a community health worker. So a lot of times when we're running programs in the field, we find the word community health worker to be a bit awkward, a bit not always perceived by the population that we're serving as the best term for the person that we're putting out there. So when we talk maybe in our grants or when we talk internally or in publications, we'll use the word community health worker. But when we're in the field, maybe we'll use the word peer supporter or patient navigator or asthma health coach or something like that. So a lot of times people are saying, oh, you're not supposed to use these terms, you're supposed to use community health worker. So I'm just saying you can use whatever term you want. But keep in mind, try to promote the term community health worker as the workforce classification. And by the way, if you have questions when I'm going along, just interrupt, it's fine. I want to do a little aside on promotoria though, because this is the one exception to what I was talking about around what are community health workers. Promotoria has a different background than most of what I'm talking about and may at times take a different track than the average community health worker workforce. So the term promotores and promotoras is used in much of Latin America. It comes from the social change movements in Latin America and was strongly influenced by Paulo Freire's methodologies and ideologies about popular education. So what ends up happening is there are a lot of promotoras here in the United States. There's a lot in Chicago who really identify with this social change movement from Latin America. And along with this, it's everyone rises together, we as a community rise together. A lot of people in the promotora movement won't accept payment for their work because it's part of this social change movement. The community must grow together. So there's a lot of conflict between the community health worker workforce development efforts that are going on and the promotora efforts that are happening around what kind of trainings, certifications, payment, job criteria, all those kind of things. So just keep in mind that sometimes promotora is used as just the Spanish version of community health worker, but sometimes promotoria means something really different, and we're talking about a whole different model. And so you have to be aware that the group that you're working with might really take this very differently. So let's look at the evidence around community health workers. There's a lot of evidence. I'm just going to start with the big reviews. So there's been 2 Cochrane reviews. One was done in 2005 and another in 2010. And these are looking at data from all over the world. So most of the data in here are international data. They show positive associations between community health worker interventions and child immunization, some around infectious diseases, improving tuberculosis treatment outcomes, a lot around maternal-child health, so breastfeeding outcomes, child morbidity and mortality when compared to usual care. Not a lot in chronic disease at all, and not a lot in the United States. ARC published a review as well that summarized data from 1980 to 2008, and in terms of the quality of the data that they found, pretty mixed, so not a lot of strong, rigorous trials or anything like that in those data. The effectiveness evidence was really conflicting, but there was moderate strength of evidence for improved medical follow-up rates for blood pressure, reduced unscheduled medical visits, and then some data around asthma, which I'm going to talk about more. When they say psychosocial outcomes, they're talking about quality of life, and we've really gone further than that since this ARC review. I'm only going to talk about chronic disease data. So there are a lot of, like I said, international data, which are very different in many ways than data that I'm going to focus on here today, which is from the United States. There's also a lot of data around infectious disease and HIV, which is almost becoming a chronic disease, but I didn't put the HIV data in here, although there are community health worker data around that as well. I'm just going to sort of talk about a couple of big chronic disease categories. So type 2 diabetes. There are a couple of pretty good randomized controlled trials now looking at efficacy of community health workers versus some sort of control condition for adults with diabetes type 2, and they've shown clinically significant reductions in hemoglobin A1C. So this is a figure from the Rothschild study, which actually I was one of the investigators on, and also the Perez Escamilla study was a randomized controlled trial that showed a clinical reduction as well. The problem is most of the rigorous studies, well, all of the rigorous studies are mainly Latinos. So we need some more trials in non-Latinos, and they're happening, but the data aren't released yet. And we also need more effectiveness data in diabetes. So these are efficacy trials, and they've shown what they were intended to show, but we need to take it further and put it into real world settings. There isn't very good cost data as well yet around diabetes and community health worker interventions at this time. Asthma, which is the area that I work a lot in. There's many studies on asthma. I put up the citations for the Seattle group. So Seattle King County, James Krieger's team has really been some of the pioneers around community health workers and asthma. And they've been able to show reduced symptom days, reduced urgent care use, improved quality of life. Almost all of their stuff had been in children, and recently, though, they finished a randomized controlled trial in adults as well that showed improvements in symptom days and some morbidity, other measures. And they've also done some cost studies. So in one of their pediatric studies now, they have a 1.9 return on investment gain with the community health worker intervention. Most of their data show improvements around some of these morbidity measures, and then regarding home triggers. Still no one has really shown that they can improve medication adherence in asthma, so that's a big open area. And we also need more data on how you integrate asthma programs like this into real world settings. So I'm working on an R01 study right now funded by NHLBI, where we're putting community health workers in the Erie Family Health Center FQHC system. And you're going to get randomized to either a community health worker for asthma or a certified asthma educator. And what we're looking at, how well are their asthma outcomes, but also the re-aim criteria. So if anyone here does implementation science, we're looking at the acceptability and the cost and all these other factors about how does it really work when you put them in the real world setting and try to let the model run. So that kind of stuff is coming, but it's not available yet. There are there's a lot of evidence around asthma as well from other sites. Cancer, I struggle with demonstrating the data on cancer because there's so many people working with navigators, usually is what you call it in the cancer field. But when you really look at the published data around the efficacy of community health workers and navigators in cancer, you don't get that much back. So there's a lot going on, and they've definitely been able to show for people who've had screening, for women who've had screening around breast and cervical cancer, having a navigator or community health worker helps improve the initial treatment, receipt of proper treatment, improve quality of life after the diagnosis. Community health workers have also been shown to improve rates of screening mammography, but we don't have good data across the entire cancer care continuum, so from before screening all the way to end of care. There's a lot going on in like colon cancer, but not all of it is rigorous or done yet. So, and there's so many different types of cancer. So there's definitely a need for all the different types of cancer, the different ranges of where people fall and what kind of goals you have within that, and then also different types of populations. For cardiovascular disease, there's been a bunch of of trials around community health workers and hypertension. These have been going on for 20-some years now. So the citations I put up here are actually meta-analyses, but definitely it's been shown that community health worker interventions can reduce blood pressure. You still need to take it further, and people are, like, so you can get the blood pressure down, but are we reducing mortality and things like that? And those data are not available yet. However, NIH has really been excited in the field of community health workers and cardiovascular disease, and has a whole series of community health worker training and implementation manuals that you can find online at NHLBI. So this is one of the ones for community health worker training around cardiovascular disease for African Americans, and then there's ones for American Indians and Latinos, English and Spanish. So there's a lot of materials. They haven't, they're based on not the most rigorous evidence. But they're there, and they're available, and they're very nice manuals. This is an area that a lot of people are really interested in. So independent of which disease we're talking about, can we reduce 30-day readmission, right, with community health workers? So a lot of what community health workers do is help people figure out how to navigate the system. They do a degree of care coordination, and with the penalties that go along with 30-day readmissions, this is an area where a lot of people are pouring a lot of money. And this trial published their data last year. You were randomized. These are adults with multiple chronic conditions that were hospitalized on the general medicine floor and then discharged. And some got a community health worker intervention at the time of discharge, and some did not. And the people in the community health worker arm were more likely to get post-hospital primary care, so they were more likely to see a doctor, a generalist after the hospitalization, which is good. There was no difference between those who received community health worker intervention and those who did not in terms of 30-day readmission, which was a bit of a disappointment, I'm sure, to the authors, although they did say that there's more likely to have the community health worker arm participants were less likely to have multiple readmissions. So there are a lot more studies that are going on around this. There's a big study at UIC which is looking at COPD and sickle cell and a bunch of other conditions, and providing a patient navigator, community health worker, to see if they can reduce this readmission rate. And I know that there's other studies across the country as well, but we definitely need more evidence in this area. So despite all, so what I presented to you is that there's a lot of evidence starting. There's some good trials out there, but there's a lot of gaps as well, right? So a lot of gaps, but that is not holding people back. So we are moving forward with policy and implementation. So first I want to just give sort of the history then of community health workers in the United States to put a little context around how this has been building and developing over time. So the Federal Migrant Act of 1962 and the Economic Opportunities Act of 1964 mandated outreach efforts in neighborhoods with high poverty levels and migrant labor camps. So that was sort of the first kind of federal efforts around community health workers. And then Indian Health Services deployed and trained community health representatives, which were the first and still remain federally funded community health workers. So on most of the reservations in the United States, there are active community health workers funded by the federal government doing really grassroots community health worker work. And they're some of the people who are leading a lot of the national efforts as well around certification and training. And they serve as a model for those of us here in the United States. The IOM report of 2002 on equal treatment called for the support and evaluation of community health worker work and CHW integration into the medical team, so a big call out for community health workers. In 2007, the American Public Health Association created a common definition for community health workers, and that was that first definition that I placed up there. This is the definition that is still promoted really widely and is used the most in the United States. This is also the definition that HRSA used to build their 2009 Department of Labor Standard Occupational Classification. So there are some differences a little bit between the HRSA definition and the APHA definition, but they're very minor, and actually APHA is currently lobbying HRSA to fix that. So there's a lot of partnership between that. Legislation efforts change by the minute. So if you want to know by the minute, I suggest you check out one of these websites. But there's a very nice website put together that this is the map that you can, it's an interactive map, so you can hover over the different states and see what kind of legislation efforts are ongoing in those states right now. And also there's a national movement that's called the C3 Project that is going to any day now release a document, a recommendation that has been built from experts in the field over the last year and a half. And this recommendation is going to be around training, certification, credentialing, and legislation and policy efforts that should that they're going to recommend everybody adopt. So a lot of us who are building legislation efforts on the state level have, like I've seen the document, right? And we used it to build Illinois. So ours in Illinois is going to mirror the national ones. But some states have been doing and building kind of off their own ideas, so they're not matching. So you can see that we're going to have some workforce issues because states are going to have certain definitions, credentialing, certain legislation on the state level that's not going to carry over to other states. And like any workforce where there's a credentialing process, it's going to put a restriction on community health workers if they can only work in one area and not in another state, say, if their training is not recognized. But it's unlikely that any of this is going to be anything other than a recommendation on the federal level, and then it's going to require state level legislation. But I'll go into this a little bit more. So where are we in Illinois? In 2014, House Bill 5412 was signed into law. So this is now a public act, and what it created was a community health worker advisory board. One of the really important things about this advisory board is that half of the members were community health workers. So this was an effort that was supported by the American Public Health Association, and that there was a lot of grassroots effort here in Illinois to push forward so that the workforce is determined by the people in it, okay? And that's, you may say, well, of course, duh, but when you're talking about, if the average community health worker, say, makes $35,000 a year or so, they're not always the kind of people that are at the table when these kind of discussions are happening. But there was a lot of support and lobbying, and they are at the table, and they are mandated by law to be at the table. So one of the things that the federal recommendations state is that certification efforts and legislative efforts on state levels involve community health workers in a majority of in the majority context. So the board was created in 2014, and I'm actually on the board. And so we spent the last year making our recommendations for Illinois. Now, they're not binding. They're just recommendations. We sent them to Governor Rauner. We'll see what happens there. But they're out there, and you can read them. So, but it was a great collaborative effort that happened with stakeholders and with community health workers and a bunch of people, legislators from around the state. So what our recommendations include are recommendations around what are the core competencies of community health workers, what are the roles that community health workers should have, what are the training recommendations and certification recommendations around that, and how should we finance community health workers here in Illinois. So that's nice that everybody's making all these policies and legislative efforts, but when you really ask people, when you ask health administrators and hospital administrators, what do you need? They're like, we need to figure out how do we pay for this, okay? So this was a webinar was conducted by the National Academy for State Health Policy, And it was, I'm told, I wasn't on the webinar, but a colleague of mine was, and it was the largest attendance that they've ever had. So it's a national webinar that was put out by this group. They had this huge attendance. They did a live poll during the webinar, and the number one thing that all the hospital administrators said is they need help financing the work of community health workers, figuring out how to pay for it. Also, of course, interested in defining the roles and scope, which is what a lot of these legislation efforts are trying to do, training and certification, partnership, but really, how do we pay for it? So who's paying for it? It's mostly coming from the public sector, okay? Federal, about 50%, that doesn't really add up, but a large portion is coming from federal and state, okay, is where the majority of funding, and then there's some coming from private and other random sources. The Affordable Care Act opened a window for potential for CMS funding, so Centers for Medicare and Medicaid funding for community health workers. So there is language specifically in the Affordable Care Act that addresses community health workers, specifically Section 5313. And then there's also, there was this there was a final rule made in July of 2013 that said that that the community health workers could be covered. I mean, they kind of laid it out that a community health worker service could be covered if supervised by some sort of licensed practitioner or professional. Now, just because it was put in there doesn't mean that anyone's been able to actualize and actually bill for this, okay? So it opened a door, but then how do we realize this is what states are trying to figure out. So I'm going to throw out 3 ways that this is being looked at in different states. One is a state plan amendment. This is a mechanism that makes sort of a statewide policy change that gives the community health worker provider status. So it's good in that it would allow for the states to bill under this Affordable Care Act. However, it's politically challenging, and people are afraid of the costs that it'll incur. They're afraid of what does that mean? You know, is this person a professional? Are they not? There's no standardization for training and certification, neither on the state level nor the federal level, so how can we be billing around this? So there's a lot of confusion, and only 2 states have managed to have state plan amendments, and both of them have gone non-traditional routes. So Minnesota had a state plan amendment before the Affordable Care Act was even released, and they pushed this through in 2007 through some channel that they figured out. But the community health workers can bill through their approved licensed providers, so they can do their services, but it's barely used is the bottom line, because I'm not sure that the uptake is really low. I think there's a lot of issues in terms of its implementation. So even though it's on the books in Minnesota as being an option, it is definitely not utilized in the way that most of us would hope that it could grow to be. Yeah.
Does the ACA say anything about billing community health workers?
Not that I'm aware of. This is it. This is all that I've ever seen around it. So it's always been coming through Medicaid, which is then again pushing us into the state level. And there's all this diversity on the state level. So it's making for a lot of challenges, definitely. I could be wrong, but we've been talking about this on the national level, and this is all that's ever come up. South Carolina also is working on an SPA application. They've internally been doing some billing of CHW services under approved licensed providers in these sort of pilot programs, but it's unclear yet what kind of final CMS approval is going to be granted, if any. Another way to think about ways to incorporate community health workers would be through the MCOs, through the managed care contracts. So this is a big hot topic in the Chicago area right now with all the MCOs. And this, because they have a capitated payment, you get a capitated payment per person in your MCO, right? So how you spend that money is up to you. So you don't have to defend anymore the billable service of the community health worker. You could just have community health workers as part of your team, right? And since you're not billing for each individual service, you're just getting the capitated payment, it allows you an opportunity for bringing in community health workers into your care team. The problem is the capitation rates are set on historic costs, and historically we haven't had community health workers as a part of our healthcare teams, so the reimbursement rate's not high enough to fully incorporate them into the system. So, and so then there's been reluctance by MCOs to accept this model. Michigan is taking this to heart, and their MCOs are requiring that their contracts offer CHW peer support specialists to members with significant behavioral health and complex care needs. We've been working a lot on some projects with Medicaid and working with a lot of MCOs and some of the work that I do at UIC, and pretty much every MCO that I'm aware of has some sort of community health worker type language in the services that they offer, although what they define and how they actually deliver it is really much different than sometimes the more robust efforts that I think they wish they could do and that we wish we could see. There's some people working on a loophole to this. So there is a CMS rule change that's been proposed to allow payments for CHW services to be counted as a cost of quality improvement or cost control, and so therefore not an administrative cost. And this is getting a little bit out of the area that I'm real comfortable talking about. I do a lot of policy work, but I'm not an expert in these fields. But what they're trying to do is figure out some sort of creative ways for billing for community health worker services on top of some of the existing contracts. And a third way are these healthcare reform initiative-driven statewide transformation waivers. So waivers are a common way for state Medicaid offices to kind of personalize or get around certain regulations. A lot of states are using waivers to cover CHW services, but again, there's going to be challenges in terms of how you cover the actual costs for the community health worker services. So there's a bunch of questions still out there around community health workers that I want to address before I open things up. And these are around the who, what, when, and how, okay? So who should be a community health worker? We say community health workers are part of the community. Well, what does that mean? We have community in their name. What is community? Is community defined by your race, ethnicity? Is community defined by your geography? Is it defined by your socioeconomic status? Is it defined by your disease? And there's people arguing viciously around a lot of this kind of stuff, and the evidence is mixed. Sometimes you really do want a community health worker who matches you on say, race, ethnicity, or geography. But sometimes just having shared experience with the disease is sufficient, and there's a lot of variability in this. What kind of degree is needed? So if your patient population is primarily high school education or lower, and you're sending master's level educated community health workers into the field, are you really following the model, and can you expect the same kind of outcomes as what you would if you were to send a lower educated, someone with a lower education level into the field? Because if you think about, again, the way that the theory about how they work is really through empowerment, through support, and through shared life experience. And if your shared life experience is really different, you may be a really great communicator, you may even share the same race, or maybe you grew up in the same neighborhood, but you have a really different life now, right? So sometimes the degrees, there's a lot of discussion around what kind of degrees are needed. In the at the state of Illinois, the job classification for community health worker used to require a college degree. And just last year, we finally, through a lot of headache, got that changed so that we can hire people as a community health worker with a high school education now. But those are kind of things that have to be thought about in terms of what kind of matching and who should be your community health worker. I'm not saying one's right or wrong, okay, but it's something that definitely needs to be considered, and you have to really think about your motivations for why you're choosing different levels. When you hire someone to do a difficult job, go into people's homes, people with a lot of problems and people who may have psychosocial issues and health issues and all that, and you're hiring someone who's almost exactly like them. Imagine the workforce issues you're going to have in terms of managing that community health worker, right? I mean, that's why a lot of people choose the higher level person as well, because they're an easier person to employ, they're an easier person to manage, they're going to have less job turnover. So there's a lot of challenges with defining the who and fitting them into your system. The where. So should community health workers really be from the community, about the community? Or are they really more about the medical system going into the community? And do we lose the grassroots, the kind of community aspect of a community health worker when we employ them through the hospital system versus when they're employed through some sort of community agency, or when they were working for the church and they were doing all this outreach and all this kind of stuff, and they were so great, so you hired them in your cancer center to be a navigator. But now they're a University of Chicago employee, and they got the badge, and they got the coat, and they got all this stuff, right? And they got benefits, and they have a really different life now and they're advocating for the University of Chicago now, and maybe not for the church anymore, right? So we really struggle with trying to figure out where should community health workers be on this continuum, and where should their identity lie. So should they have a day a week, like 8 hours a week, that they do community service? Because many of us would advocate, yes, they do. If you really want them to be community focused, then you need to allow them to be in the community. Or sometimes we do partnerships where the medical system, the medical center partners with the community service, social service agency, and the community health workers are actually part of that social service agency, not part of the medical center. And that's a way that they can keep their community focus while also serving the needs of the medical center. So there's people trying to figure this all out, but it's definitely a spectrum, and there's challenges all along the spectrum, and you have to figure out where your team is going to fall and how you're going to keep the clinical focus, if that's what you need, but also keep the community drive behind that. So again, are we adapting community members to the healthcare delivery system, or are we adapting the healthcare delivery system to the community environment? And it's your lens that you have to think about in terms of when you're planning these programs, what you want to have happen. And then the how. So what types of interventions? Are we talking about groups? I showed you that NHLBI community health worker cardiovascular disease curriculum. It's all group-based. So community health workers do group sessions for groups of adults around preventive behaviors. Should it be individuals? Should it be one-on-one type things? How many sessions? Do you need 12 sessions in a year? Do you need one session every month? Do you need just 3 sessions? How do you know? Is one, because let's think about how we would approach this with a medication, okay? If you have high blood pressure and I'm going to put you on a medicine, I'll start you with what I think is a good dose, right? And then I'll check you, and if you're not responding, then I'll increase it, right? And I'll keep messing with your medicine until I get you to where you want to be, or where you need to be, right? And then I'm not going to just pull away your medicine, because if I take away your medicine, what'll happen? Your blood pressure will go up, right? But yet we look at the community health worker intervention, we're like, okay, how few times can we interact with this person and then expect a lifetime of change, right? So it doesn't work that way. But one person may achieve whatever behavior change we're looking for with just several sessions with a community health worker. and yet another person may need a lot more work, right? And everybody's going to need maintenance. And yet none of the research is really there yet to help us figure out how we do this and how many sessions we need and how do we tailor it to what people need. So we're really struggling on trying to figure that kind of stuff out. How do you engage community health workers into the clinical team? All right. In the past, there's been a lot of hostility between, like, say, nurses and community health workers, nutritionists, like, well, what, she's coming to take my job? Oh, no, she doesn't want your job, right? She's here for a whole different purpose. But many people don't understand the role of the community health worker. I'll say where I practice, in my clinic, we have 2 community health workers. They are never doing community health worker work. They are manning the front desk, they're answering phones, they're doing this, they're doing that, they're rooming patients, because they get pulled to all these different jobs because they're around and they're flexible and they're smart and they're great. But the team, the system there doesn't know how to protect them and how to integrate them and how to really allow them to do the work that they were trained to do. So you need to figure out how to have this new workforce as part of your clinical care team. And we're doing experiments. That's my trial. That's the study that I described to you with asthma, is what we're trying to figure out is how do we get the community health worker to be an effective part, a useful part of an asthma outpatient pediatric care team. And so this has to be developed yet. How do you communicate between others? And especially if your community health worker is not physically located in the clinical care center, right? So then how does that happen? We have a lot of data on efficacy, but not a lot on effectiveness, so we need to see what happens when we put this into real-world settings. How to maintain effects as the number of clinical targets increases, okay? So community health workers look at the whole person, the whole family, sometimes the whole community. And yet, you know, me, the doctor, I'm like, so how's their asthma? How's their asthma, right? Like, that's all I care about. And they're like, oh, God, Dr. Martin, okay, fine. Their asthma's getting better. But, you know, Grandma had a heart attack, and Dad's in jail. And you know what I mean? So, and if we start really embracing all of the different kinds of things that community health workers can do, how are we going to measure that, first of all? How are we going to really understand the different kind of areas that they're intervening? How can we measure it? Can we look at multiple clinical targets at once? And what kind of effects? Would we see a diluting of an effect if we really truly allow them to just hit all their problems? Just go for it. Maybe we'll see a dilution in the effect on asthma, but we might see an overall improvement in some sort of greater quality of life scale or in some sort of utilization or cost scale, right? So it gets more complicated when you allow them to, and when you really recognize maybe a broader spectrum of what they're capable of doing. Who should train them and how? Okay, licensure, the whole workforce would say, no, please don't license us, okay? Oh my God, it would be a nightmare. But certification is coming. The Promotoria movement would prefer not, but certification is coming. And it'll be again on the probably state level. Right now, there is a program at South Shore or South Suburban where you can get a associate's degree in community health work. There are going to be other community college programs. There's going to be different stages, almost like sort of a EMT kind of does, where you have like stage 1, where you just have like a basic skills level in community health worker skills, and then there'll be like more specialized. So say you've done an asthma training, or you've done a special cardiovascular disease prevention training. So then you're sort of like the tier 2, you're specialized, and that would affect your pay grade and different things as well. Then there's the trainer, so there's the community health worker who now trains other community health workers, right? So who's almost been now put into a supervisory position. So these are the levels of certification that are going to be coming. They're not here yet, though. So right now, when you want to hire a community health worker, you oftentimes have to create your own curriculum, and you have to create a lot of your own materials and criteria around this. But the national guidelines, the state guidelines are meant to try and guide this process further. And who should do this? Do we want the state certifying? Do we want community colleges? You know, who do we want doing this? Mm-hmm.
Do you have any sense of what proportion of community health workers have a full-time job doing that versus, you know, they get hired hourly to do 10 hours a week on this project?
We don't even have any clue as to how many community health workers there are. So, because again, there's so many titles for it. In the past, there was a lot more in the sort of hourly and volunteerism range. About 5 years ago or so, we did a survey in Rogers Park where we just took one community area and we inundated it trying to figure out where were all the community health workers. And a large portion, I think 40-some% of the community health workers we found were working either as volunteers or just on stipend, like hourly kind of things, like not a real job basically, right? And then the rest were some sort of actual real employment with either part-time or full-time. So certification will help that kind of stabilize as well, and will again put more standards on, the going rate is anywhere from $8 to $18 an hour. So a pretty big range. And to try and put more kind of guidance for employers and for agencies around how to work with community health workers fairly on this. And the payment, who should pay, right? Should this come from healthcare plans? Should this come from the government? Should this be something that private payers do? Should this be some sort of community service? You know, there's a lot of question as to where the payment should come from. So to summarize, there's a good deal of evidence around community health workers. Strong in many chronic disease areas, but definitely lacking in effectiveness data and a lot of implementation data, and we definitely could use more trials. However, regardless of all that, implementation's moving forward, and it's coming right now, so no one's waiting on the data, but the data will help us guide some of the things that we're doing over the next decade. There's a lot of workforce and funding issues. There's a lot of national and state legislation that's in progress as well. And when we just think about our case studies again, so the woman who's not going for a screening mammogram, it would be great if we could refer her to a patient navigator, someone who could talk to her, figure out what are her barriers, what are her fears or confusion, because she may have, maybe she just didn't really understand what you said, but maybe there's everyone in her family, whenever they go for that mammogram, they find cancer and they're dead in a couple years, right? I've heard people say this, I don't want to go for the mammogram because it's just like a death sentence in our family. Navigator can talk to her, help her understand, and get her hooked in and get the mammogram done. The man with diabetes, be great if we could send a community health worker out, go find him, go knock on his door. Track him down. He's in the ER? Go, right? And we do this at UIC with some CMS-funded community health workers that we have. We find them, we track them down, figure out, okay, so you don't have a phone, I get it. Who around you has one? Who can we contact? How can we reach you? And maybe phone's just not the way, but we know that he's always at a certain place on a certain day, so we can find him that way. Maybe he qualifies for, a phone subsidized by the state or something through his health care plan because of his disability, and we can get him that service, right? So we can now reach him, which is great. Maybe he's not getting Social Security. He should be getting Social Security, and here's an added source of income so he becomes a little bit more stabilized. We could educate him on his diabetes and how to use the healthcare system. You can call and you can see your doctor that same day. You don't have to go to the ER. They're open until 8 o'clock, and there's a Medicaid transport bus. Like if you just call the day before, they'll pick you up, let me set it up for you, show you how this works, right? So help him figure this out and maybe use the system a little bit more proactively. And in terms of our little boy with asthma, it would be so awesome if you could send him to a community health worker. The community health worker could go out to the home, look for triggers, try and figure out what's going on in this house. maybe there's some serious housing issues, right? And you got to call the housing authority and get them out there to fix the holes in the wall, the mold. Maybe they need some sort of change in their housing. Or maybe they just really don't understand how to use all these devices. You're pushing all this medicine into them and they're not really using it because they don't understand how it works. Or everybody in the house has asthma, and even though you send him with the inhaled corticosteroid, they're sharing that among a family of 4 because none of the adults have insurance, right? So the community health worker can go to the home, figure these things out, connect the family with the right resources, and come back to the provider and say, did you know this kid's got a hole like this big in his wall? There are cockroaches, there are so many things. Have you and then you say, oh my gosh, we should allergy test him, we need to get him into better housing. All kinds of things like that. And so maybe the answer isn't added care, maybe it's more medicine, maybe it's some sort of social intervention. So with that, that was a lot of information I realized, but I'll take questions. Thank you.
Thank you so much.
Thank you.